Hello, thank you very much for having me. It's fantastic to be involved with the SGCR Wires conference. And thank you also to Canon Medical, not just for the opportunity to present, but also for the opportunity to be, as it turned out, one of the first in the world to trial their new ultrasound system, the Canon Aplio I-Series Prism Edition. And today I'll share my initial experiences and some case studies with this system. My name is Aaron Fleming. I'm a sonographer that works for QScan Radiology. I'm based at the Red Hill practice in Brisbane. And that practice is within the High Performance Centre of the Brisbane Broncos, one of the biggest clubs in the National Rugby League. And we provide the imaging not just for the Broncos, but also the Queensland Reds in the Super Rugby and the Brisbane Lions in the AFL, as well as numerous other elite and professional sporting organisations, including a number of athletes currently representing Australia at the Tokyo Games. So MSK is at the forefront of what we do at this particular practice. And this is where my passion and predominant interest lies. That is the reason why I got into ultrasound. But when I started musculoskeletal ultrasound, I quickly became frustrated and disillusioned. It seemed to be such an arbitrary and subjective discipline. And one of the game changers or turning points in that way of thinking was the advent of version 2 of the i800. I thought this enabled us to visualise anatomy and diagnose pathology that were previously beyond the realm and capabilities of ultrasound. And I found that the incredulity of a number of radiologists was lessened due to the strength of the images produced. So when I was offered the chance to trial their new ultrasound system, the version 6 of the i800, I was really excited to see what this had to offer. Now, I had around 4 or 5 days of scanning on this system. Now, that's not a long time, and in such a short time, the most striking features will be those that are new and or significantly improved. Immediately, I was taken aback by just how customisable this machine is. Similar to previous models, you have control in the way that the control panel and user interface is set up. As a sonographer, it can be frustrating when you have a machine or model upgrade and you have buttons and their subsequent functions in completely unfamiliar positions. There's no such, with this machine, there's no such time lag for that, to account for that. The other important or a cool aspect to this was custom precision. I'm a sonographer that will adjust amplitude and precision for essentially every patient I scan, and these adjustments are not necessarily always the same. They will be governed by patient habitus and the pathology demonstrated. And with this system and custom precision, that allows you to take that a step further. You can essentially adjust precision 5 to 6-fold on what you could previously, which essentially enables you to control the smoothness of the image to one that suits your eye. And given the fastidious and finicky nature of sonographers, this is such a smart addition. Some of the imaging processing capabilities were very impressive. I found myself using I-beam plus and full focus quite a lot. With this, essentially the machine will automatically adjust the focal zone of the beam and the image. So instead of continually adjusting the focal zone of the ultrasound beam, the machine does all the work for you. And I found in many aspects this improved the quality of the picture. The electric lift button essentially raises and lowers the machine. As a sit-stand sonographer, I found I utilised this on every single patient that I scanned, and it was something that I missed when this was taken away. And some of the additions to SMI were very smart. SMI has always been a great tool for assessing microvascularity and low flow states. But with SMI G4, the versatility of SMI is improved. Essentially, you can use SMI with higher scales, and there is no degradation to your background beam mode image. So here we can see it in a post-radiation therapy CCA, and if we juxtapose that to some hypervascularity of a torn RCL in the little finger, that is testament to just how versatile SMI is. The other cool component is Doppler luminance. This will give you a 3D or bubble type appearance to your vascularity images, something that is really popular in a lot of obstetric models and adds to the aesthetic appeal to the image. Here we can see it used in a tennis elbow, and we can see it used in a tenosynovitis of EDC of the wrist. and here used with the split screen modality to show the presence of a testicular infarct. Now, all of these additions and features mean very little unless your image quality is top shelf, and herein lies the strength of the Prism Edition. Now, the best way to showcase this system is through some of the images captured during those 4 or 5 days. And in doing so, it is important to appreciate that these images do undergo a degree of compression. There is not a true projection of these images from what you see when you are scanning live, but they are nevertheless really great images. Now, I didn't want to regurgitate image by image and case by case. Instead, I thought I would just show some cool snippets of cases or some aspects to cases that are often overlooked or misunderstood. In this way, hopefully this will be entertaining and somewhat educational in keeping with SGCR and the educational ethos of Canon. So the first patient was a professional ballet dancer. They'd had a scan elsewhere that showed EDL tenosynovitis, and they came to us for a HCLA injection. Now, it wasn't EDL, it was EDC, and it wasn't a tenosynovitis, it was a ganglion. Now, there's not too much exciting about a ganglion, but this particular ganglion was located between extensor indicis and extensor digitorum 2. It is a lesser known fact that there are 2 extensor tendons to the index finger, with extensor indicis located on the most ulnar aspect when you are scanning from the dorsum of the hand. This can be harvested and used as a graft for any tendon or pulley repair when, say, palmaris longus is absent. This is a trigger finger. Often when we get referrals for trigger finger, our instinct is to measure the pulleys, say the pulleys are thick, and say that that is the cause of the trigger. It's not always the case. Here we can see some nodularity of the flexor digitorum superficialis, and there is a tenosynovitis of that sheath, and this is ultimately responsible for that asynchronous movement during flexion and extension of that index finger. This was an elite AFLW player. She hurt her thumb in a contest and had pain at the MCP joint. And often any MCP joint pain, the emphasis on the UCL and either identifying or excluding a sternal lesion. And that's fair enough given the significance of such a lesion. But it's important not to overlook the RCL of the thumb. In this case, we have an avulsion fracture of the first metacarpal, and we have a high-grade partial thickness tear of that RCL. Now, the subsequent X-ray was normal, and it is important as sonographers and radiologists to realise that an X-ray does not always exclude a fracture. Ultrasound is fantastic for identifying those X-ray occult fractures. Here is an avulsion fracture of the volar plate of the little finger, and we can compare that with the contralateral side using our horizontal split screen. Again, looking at the flexor tendon mechanism, we can see the insertion of both bands of flexor digitorum superficialis and campus chiasm. And it's important when we have to assess for any tendon injury post-laceration that we assess the full complex of the flexor tendon. That involves also identifying and looking at the digital nerves of the fingers. These are often involved in finger lacerations, and these can be repaired by hand surgeons. And you can see with this system, we can see really clearly full definition of those very small but very important digital nerves. This is one of the cooler cases I scanned during that time. This was a lady who presented with a lump on the palmar aspect of her hand query dupotrons. Now, on asking the history from the patient, she said that she heard it at yoga, and there was some pain on flexion and extension of her index finger. And here you can see both flexor digitorum superficialis and flexor digitorum profundus of that index finger. And you can see quite a large hematoma surrounding this area, particularly on the undersurface of the flexor digitorum profundus. If we're scanning in transverse, again, you can see that gross hematoma. And on flexion and extension, you can see some abnormal movement of the flexor digitorum profundus. Now, this is a tear of the first lumbrical muscle of the hand. And we have that abnormal movement because the origin of the lumbrical is on the undersurface of the flexor digitorum profundus. A really cool case and something that's quite rare and in the literature. If we move down to the foot now, this is the insertion of the lateral band of the plantar fascia onto the fifth metatarsal. If anyone presents with pain at the base of their fifth metatarsal, it is invariably pathology in the lateral band of the plantar fascia that we'll discover. Peroneus brevis is often completely normal. Now, it's the lateral band of the plantar fascia responsible for these Jones or MT5 base fractures on an ankle inversion injury. So it's a really important area to assess. Here is the deltoid ligament. We can see the posterior tibiotalar component of that deltoid, and we can see that that extends in between FDL and the posterior aspect of the talus. This is indicative of a thickened deltoid ligament and some synovitis. Now, if we move on to the tarsal tunnel, this was a truck driver, and after 15 minutes of driving, he would have numbness and paresthesia on the plantar aspect of his right foot. Not a good thing in a truck driver. Now, he had multiple investigations and intervention for back issues that failed to resolve his issue. On scanning, we can see quite a moderate effusion of that FHL tendon sheath, and often this is an ankle joint effusion that decompresses into that FHL tendon sheath, and this can quite often be asymptomatic. But if we dorsiflex his ankle and his first ray, i.e. we put his foot in the position that it is when his foot is on the accelerator, we can see that there is an involvement of that tibial nerve just before the bifurcation of the medial and plantar nerves, and just before, in this case, the origin of the medial calcaneal nerve. So we aspirated the FHL and injected, and he reported absence of the symptoms thereafter. In a similar case, this was a lady who had 3 PRP injections onto what looks like a relatively normal right plantar fascia. And often if someone presents with plantar fascia type pain and the plantar fascia is normal, it's then that we must go to the tarsal tunnel to look for a secondary cause of that plantar heel pain. In this case, there was a subtalar joint ganglion impressing upon the tibial nerve at around the bifurcation of the medial and lateral plantar nerves, potentially accounting for her recalcitrant heel pain. Now, the plantar plates, the significance of the plantar plates cannot be understated, but they are often underappreciated, particularly from an imaging point of view. The collateral ligaments of the toes will plug into the plantar plate. So if you have a plantar plate tear, you will have a deficient collateral ligament. If you have, the collateral ligaments are capsular ligaments. So this predisposes the joint to fibrosis and scarring, and this can manifest as an intermetatarsal mass that is often incorrectly diagnosed as a bursa neuroma complex. In this case, we have a partial thickness tear of the lateral aspect of the plantar plate, and the interdigital nerve is normal. We can see the superficial and deep borders of that nerve really well in longitudinal and in transverse. If we scan from that plantar plate out, we can see that there is this area through here. This is often measured and identified as a bursa neuroma complex, but this is in fact pericapsular fibrosis from a torn plantar plate that is impressing an otherwise normal interdigital nerve. So the pathology in this instance is the plantar plate and not a neuroma of that interdigital nerve. Here we can see a true Morton's neuroma. We can see thickening of that nerve, and in the same patient there's a positive Mulder's click. Now if you look at some shoulder injuries, often with shoulders we are asked to assess for bursitis and impingement, and there's numerous literature being produced now that says that impingement is an outdated and essentially incorrect term. We need to look beyond bursitis and impingement. In this instance, there is a small biceps effusion. There is some thickening and hyperemia of that rotator interval. We can identify the the CHL at its proximal origin. And we can see that there is thickening of the inferior glenohumeral ligament and axillary recess when compared to the contralateral side. Now, this represents an early adhesive capsulitis, a really important diagnosis to get early, and one that is well within the reaches of ultrasound. You don't need an MRI to diagnose adhesive capsulitis. This was an elite rugby league player who presented with extensive bruising across the chest and medial aspect of the arm, similar to what you would expect in a pec major rupture or a biceps rupture. We can see proximally the long head and short head biceps are intact. The distal musculotendinous junction of biceps brachii is normal, and the pec major insertion was also normal. Now, I spent about 20 minutes looking for the source of the bleeding and eventually found it in the anterior and middle deltoid. Here we have an intramuscular hematoma consistent with a cork injury. Here is the UCL of the elbow, or the Tommy John ligament, really important for our overhead throwing athletes in cricket and in baseball. And there we can see a small calcific focus consistent with a previous injury. And in the last case, this was a professional fireman. He had pain with pronation and supination of the hand. And we can see a high-grade partial thickness tear at that distal biceps brachii insertion. Now, we can differentiate the long and short head of the biceps distally. And in this case, this injury was confined to the long head of the biceps distally, consistent with that pain in pronation supination. And in this view, we are looking at the reverse Leighton-Hewitt, or the Cobra view, and we can see mainly the long head of the biceps in this instance. Now we can view this in a different way as well. You can see abnormality of that distal biceps brachii, and we can extend that further looking at a normal distal musculotendinous junction. Again, hypervascularity consistent with that tendinosis from that partial thickness tear. So now I'm going to present or do a bit of live scanning looking at some peripheral nerves. So here we are on Canon's i800 Prism Edition, and we're looking at some peripheral nerves of the upper limb, an area that, in my opinion, unequivocally trumps MRI in terms of imaging. So we're going to start off with the 18 megahertz linear probe with I-beam plus and full focus. So the machine is automatically focusing the beam and the image. And we're going to start off with the radial nerve. So I'm at the anterior aspect just proximal to the elbow joint. This is the radial nerve here, and as we slide down, we can see the radial nerve will bifurcate into the superficial radial nerve and the posterior interosseous nerve. So the superficial radial nerve is slightly medial, and as we come down, it will run underneath brachioradialis all the way down to the wrist, and this can become implicated in a de Quervain's tenosynovitis. We'll pick that up at the distal wrist joint in just a moment. If I come back, often we are asked to assess the posterior interosseous nerve at the arcade of Froese. This is significant when people will present with common extensor tendon pain, but their common extensor tendon is normal. Once that's normal, we are then going to assess the posterior interosseous nerve as it comes down. And here it's going to dive down into the supinator muscle belly here. Now this is the arcade of Froese. So as I turn long onto that, we can see posterior interosseous nerve proximally dive down into the arcade, and we can follow that through the supinator muscle. Here we are looking for any potential fibrosis at that arcade, and often you can have a ganglion coming from that elbow joint that will come up and impress upon the posterior interosseous nerve. Now we can follow this nerve all the way down through the supinator canal as it exits the supinator canal as well. You can also pick this up distally at the wrist joint. So I'm just going to swap over probes now to the hockey stick. I'm going to look at that superficial radial nerve at the level of the wrist, and this can often and cause issues when we have a dequervains tenosynovitis. So here is that superficial radial nerve. We can scan proximally, and we're just going to dive under brachioradialis here. As we scan down, it is going to flick over the top of our APL and EPB tendon sheath at this point here. And we can see that flicking over those tendons here, and this can often be the cause of that clicking that people with dequervains will describe, and that can be quite painful. Often this is important to identify prior to any interventional work from a radiologist point of view. Often when we're doing a dequervains injection, HCLA, this nerve can become very close to the needle track that a lot of radiologists use, so one to be aware of. If we look at the posterior interosseous nerve distally, we're at the back of the wrist joint through here, we're just under EDC. The posterior interosseous nerve distally is this little structure through here, so this is Lister's tubercle of the radius. As we come down, we can see the posterior interosseous nerve distally. Now this is very close to the scapholunate joint, and where often a dorsal ganglion from that wrist joint can encroach upon the posterior interosseous nerve, and a lot of literature will say that this is perhaps a reason why some ganglions seem symptomatic while others are not. We can see that tracking down, and that will innervate a lot of the dorsal wrist joint. So I jump back up to my 18 megahertz probe, and we'll look now at the median nerve at the wrist. We can pick it up. So I'm just proximal to the elbow here, next to the brachial artery. This is our median nerve. I'm back onto our I-beam plus and our full focus feature. We can see that median nerve come down just distal to the elbow joint now. It's going to come through. We can essentially track this all the way down to the level of the wrist. As we come down, and again, a really quick way to track that median nerve for any abnormalities, neuromas, accessory muscles. And we can follow that all the way down to the wrist there as well. So that's that median nerve as it comes down. In between FDS and FDP, you see pronator quadratus through here as well. Switch back to the hockey stick at the carpal tunnel. You can see incredible detail, that median nerve. We have FCR, palmaris longus, which is not seen on everyone. And just to demonstrate the quality of this system, we can see the palmar cutaneous branch of that median nerve as it comes up and through this area through here. So often this can become implicated when there is an effusion around the FCR, which is often from a degenerative STT joint, and that can run in close proximity to the palmar cutaneous branch of that median nerve. If we keep coming down, we can see the transverse carpal ligament, and we can see the median nerve underneath that transverse carpal ligament. In longitudinal, we can follow this all the way down into the hand and the wrist. I'm just going to pick up that median nerve just proximal to the carpal tunnel level, and this is often where we're asked to assess for the possibility of carpal tunnel syndrome. This is that median nerve. As we come down, you can see this is going to cause, this is FCR, this is palmaris longus, not present on everyone. As we come down, we can see this little branch, which is the palmar cutaneous branch of the median nerve. It'll come down, It seems to exit through that transverse carpal ligament. Now this can become involved when there is fluid surrounding the FCR, which is often from a degenerative STT joint. It can run really close to that palmar cutaneous branch of the median nerve. The median nerve, as we come down, we can see the fascicles of that median nerve really well. And we can see the transverse carpal ligament over the top as we come down into that carpal tunnel. If I turn long onto that, we can also see the median nerve coming right down, and we can follow that essentially all the way down into the hand. Incredible detail. If I jump across to the ulnar nerve, the ulnar nerve will run adjacent to the ulnar artery. This is that ulnar nerve through here. As we come down, it's going to jump through Guyon's canal. So this is the pisiform through here, an ulnar artery. This is the ulnar nerve. You can follow that further down to the wrist. And here is the hook of the hemate. And you can see the ulnar nerve will bifurcate into the superficial ulnar nerve and the deep ulnar nerve, which is the motor branch that supplies all the deep thenar muscles, will run just around the hook of the hemate. And we can turn onto that and we can see the nerve running across to that thenar eminence of the thumb, and that will innervate those thenar muscles deep to FPL. Okay.